An introduction to critical care, presented by me, your host, Pat Nelligan. Now that you've taken a history and know some background information about your patient, it's time to examine them. Good doctors examine their patients. They do so comprehensively and systematically. In the ICU, you start with the head and you work your way to the toes. I'm splitting this tutorial in half. The first part of the tutorial is going to look at the head, the neck, and the thorax. Examining the critically ill patient. Welcome back. In the previous discussion, I talked about how you can get a history from an ICU patient who can't give you a history. There are 4 W's. Who is the patient? Why did the patient come to the hospital, and why do they need to go to the ICU? What is currently wrong with the patient? The formation of a problem list. And where are we going? What are our goals for this patient's management? Part 1. Orientation and examining the head, neck, and chest. You arrive at the ICU bedside of Eddie. And when you get to the bedside, it's imperative that you take in the scenery. You stand at the end of the bed and observe. There is so much information that you can pick up before anything else happens. This is an example of the bedside of a patient such as Eddie. And there is so much going on here that an ICU specialist will pick up in seconds. For example, we have lots of machines attached to this patient. We have a monitor. We have a mechanical ventilator. We have a dialysis machine. We have an advanced cardiovascular monitor. We have a series of pumps. We have an endotracheal tube and a nasogastric tube. We have enteral nutrition, and we have intravenous sedation. Now, this patient is sitting up in the bed, which is the correct position of a patient in the ICU. But sometimes you'll come to a bedside and you'll see this, a patient who has turned prone. This patient is self-proning. They're not being mechanically ventilated. And this is a different situation. And we can tell that this patient likely has hypoxic respiratory failure purely by looking at their position. The first thing you do before you lay hands on a patient in the ICU is introduce yourself, regardless of whether the patient is conscious or unconscious. Always inform them about who you are and what you're going to do with them. For example, this particular doctor might say, "Hi, Mr. Eddie," or equivalent name. "I am Anne, I'm one of the ICU doctors, and I'm going to examine you if that's okay." Likewise, if you're a medical or nursing student in the ICU, introduce yourself to the bedside nurse and ask for permission to examine the patient. And then explain to the patient that you're a student doctor or student nurse. I prefer you don't use the term medical student or nursing student. It sounds much better to clarify what you're becoming. It's a professional qualification. So I am a medical student to the nurse. I'm a student doctor to the patient. And then inform them that you're going to examine them if that's okay. The first thing you do before you even consider examining them is to figure out whether they're going to cooperate with an examination. So you must rapidly assess the conscious level. And the way we do this is using the AVPU approach. A for awake, V for responding to verbal commands, P responding to pain, and U being unresponsive. Now, you can clarify this subsequently by either following the Glasgow coma score or if the patient is sedated using the Richmond agitation sedation score. The other thing you should look at when you're doing a quick assessment of them neurologically is to see if they're twitching or seizing or if there's extrapyramidal signs, and you'll see this on the face. And then once you've done a quick eyeball of the patient, you need to start the examination from front to back, from head to toe. It must be systematic, and you need to do it the same way from patient to patient. Now, as a medical student or a doctor in medicine, you may have a different approach where you might start on the patient's hands and work your way around while you're chatting to the patient to make them feel comfortable. I think that's very nice in medicine, but in critical care, a lot of the business is in the head, and that's where I always start. So let's start with the head. Now, remember your clinical examination basics. When you're examining a patient, you should use the same approach, which is inspection, palpation, percussion, and auscultation. Now, obviously, not every system requires percussion and auscultation, but you should rotate that around in your head. For example, when I am examining the abdomen, I always palpate, percuss, and auscultate. So we're starting with the head, and the first thing you're going to look at is the head shape. And the question you ask yourself, is the face and eyes swollen? Is there redness across the cheekbones or the bridge of the nose and chin? Because this may be due to the pressure effects of being in the prone position. You'd also expect to find some redness in the chest as well. So is the patient edematous? Conversely, you might see a patient who has razor sharp cheekbones and a concavity in the lateral aspect of their foreheads consistent with temporalis wasting, and this is often a sign that the patient is malnourished or undernourished, and that's problematic. And sometimes the way I describe this is as if you got a skull, added a nose to it, and sprayed on skin onto it. There is no flesh around the head. That patient is likely malnourished. The other thing you need to look at is the color of the head. It can provide you with a lot of potential diagnoses. Is the patient's head color normal, or are they unusually pale? If so, consider anemia. Is the patient yellow? Jaundice can be confirmed by a yellow sclera. Is the patient red, suggesting an increase in vascular activity in the subcutaneous tissues? You see this in anaphylaxis or septic shock, or yourself if you've had a nip of whiskey. Is the patient blue or purple, suggesting cyanosis and hypercarbia? This is confirmed by looking at the lips and the tongue. The other things you should look at are a pinched, tight face that is suggestive of scleroderma, telangiectasia on the cheeks and then the lips and the forehead, where you might consider liver disease, swollen or discolored lips, a recessed mandible that suggests that you might have trouble with intubation, a short neck or a fixed neck associated with ankylosing spondylitis, and you will see this from the end of the bed. When you're looking at the head and neck, make immediate note of the interventions that have been applied. For example, their patient may have an endotracheal tube placed in their mouth, a wide-bore nasogastric tube, a fine-bore feeding tube that's usually yellow. There may be a central line in the neck or multiple central lines. And finally, you may find an orogastric tube in the mouth. Always ask why this is in place. Was it because there was difficulty passing an NG tube, or is there a problem in the nasopharynx, such as a base of skull fracture? The other thing you should know about the two tubes that have been passed for life support, the endotracheal tube, you need to know what size tube it is and how many centimeters the tube has been inserted from the lips, just in case that tube comes out a bit. You should know that because you may have to reintubate the patient. Sometimes it's placed at 23 centimeters and you come by and it's down at 25 centimeters, often meaning an endobronchial intubation, or sometimes it's at 17 and the tube is sitting in the larynx. Also, you need to have an idea where the tip of the enteral feeding tube is. Is it in the stomach or is it a post-pyloric tube? Is the patient receiving CPAP or non-invasive ventilation? That is respiratory support on inspiration. And if so, what are the settings in terms of the mode, the inspired oxygen tension, the inspiratory pressure, and the PEEP or EPAP? The patient may be receiving CPAP via a helmet. And again, you want to know if this is CPAP or non-invasive ventilation. Usually it's continuous positive airway pressure. The patient may also be treated with high-flow nasal oxygen. Now, this has become so ubiquitous, people are beginning to miss that the patient is getting it. And frequently you'll see patients in the ICU on high-flow and not even process it. But you do need to know what the inspired oxygen tension is and what the flow rate is. So if they're on 40% oxygen at 40 litres, you do need to be able to take note of that and find out why the flow rate is so high. Now, once you've looked for devices attached to the patient's face, you need to start examining specific parts of the face, and you start by looking at the eyes. Often, the eyelids are closed. Patients look like they're asleep, and yeah, you have to open up the eyelids and look at the eyes. The pupils have been in the dark for a while, so they'll be large, and then they should react to the light, and you should be able to figure out very quickly that the pupils are equal and reacting to light. If the pupils remain large and the room is quite bright, the patient has a problem. Not infrequently, the patients in the ICU, once you lift up their eyelids, will have pinpoint pupils, and the reason for that is that they're being treated with continuous infusions of opioids or getting intravenous opioids very frequently. So don't be surprised if you pull back the pupils and you see these two black dots looking at you. It's also worthwhile having a good look at the sclera, because if your patient has highly pigmented skin, you may miss jaundice, but the sclera are always white, and if they're discolored yellow, the patient is jaundiced. Other things that you could look for while examining the eyes are evidence of fourth, sixth, and third nerve palsies. But be aware that if the patient is, for example, receiving a propofol infusion, the eyes can be wandering off in different directions, and ocular signs in a non-awake patient can be misleading. Now it's time to look at the mouth. The mouth needs to be carefully inspected. You need to look initially at the lips and gums and identify if there is ulceration of the lips, for example, from the endotracheal tube. You need to look at the teeth. The quality of dentition is correlated with the quality of lifestyle. If the patient has awful teeth, then you can assume that they don't look after themselves and expect poorer overall organ function. Now, if the patient is edentulous, this may be a reflection of their dentist in their youth rather than their lifestyle. The tongue is a splanchnic organ. It gives you a view of the inside of the body, and never underestimate its value. Look at it carefully. If it's coated with material that looks like cottage cheese, think about candida. Is it pink or red, or is it blue tinged? This may be indicative of cyanosis. The lips should also be blue as well. If the lips are not blue and the tongue is very deeply blue or black, this is a really bad sign. It is commonly an indication of global hypoperfusion. Once you've finished with the mouth, it's always worth looking around at the ears and the back of the head. In this situation, you can see that the patient has a pulse oximeter clipped on the earlobe. This suggests that the patient's perfusion is too poor to measure the pulse and oxygen saturation on the finger. You should also see what's attached to the nasogastric tube. If a tube is inserted, is it being used for feeding or is it on free drainage? This is important. If it's on drainage, this suggests that the patient has an ileus or they're fasting for surgery. And if they have an NG tube like this, but no enteral feeding tube, then you should ask, why is the patient not being currently fed or being given total parenteral nutrition? Now let's move on to the neck. The most obvious thing that you will encounter in the neck is a tracheostomy. Check the size of the tube. In this case, the internal diameter is 7 millimeters. Note that the tube is not always connected to a ventilator. In this case, the patient is receiving humidified high flow. Not all tracheostomies are the same. In this case, the patient has an extra long tracheostomy tube that sits proud of the neck. He also has a Swedish nose heat and moisture exchanger that is not connected to oxygen. This patient has a tracheostomy attached to nothing, but you can see the purple colored attachment to the tube. This is a one-way speaking valve that the patient can inhale through, but they must breathe out of their mouth, and because the gas travels through the vocal cords, they can speak. Note that the cuff of the tracheostomy must be deflated if this device is used. The neck may be partially inaccessible because the patient has a neck collar on. Obviously, you need to know why the collar is on, and you need to make sure that it's properly fitting the patient. We need to look at the front of the neck and see if there's a large mass, particularly a thyroid mass, in the midline. You will then move to the side of the neck and look for central lines. This is a standard triple lumen, 3 lumen central line. You will see that there is a little window in the dressing. That is not by accident. This allows you to visualize the insertion site to ensure that it's not inflamed or infected. There are different types of central lines. This is a triple lumen dialysis catheter. It's called a VAS cath in the part of the world that I live in. There is a red hub and a blue hub that reflect outward and return lines for continuous or intermittent kidney replacement therapy. Sometimes devices are inserted inside central lines. This is a Swan-Ganz catheter, and the introducer is placed into a central vein. It's sometimes called a cordus or a swan introducer, and then the catheter is threaded through it. These are big, long yellow catheters with at least one syringe attached to them and various different connections at the end. Just to point out where you have central lines in the body, central lines are inserted into the right internal jugular vein, the right subclavian vein, the left internal jugular, the left subclavian. PICC lines are inserted into the arms just above the elbow, and then we have left and right femoral central lines. And finally, porticats or Hickman catheters are placed in the superior vena cava, and they are usually placed by interventional radiology these days. You should then palpate the neck. One thing that I usually do when I'm examining an ICU patient for the first time is look for their trachea and make sure that it's palpable and in the midline and not covered by a mass. The reason for this is that we may well be doing a tracheostomy on that patient at some stage in the future. You then feel for lymph nodes along the neck and the carotid pulse on both sides. Subsequently, you should feel in the supraclavicular area for evidence of crepitus. This reflects an air leak from the lungs into the subcutaneous tissue. That's caused by, for example, a pneumothorax. Pneumothoraxes can be caused by the placement of a central line. There may also be a chest tube in situ that we will see when we examine the chest. When you're inspecting the chest, you want to see is the patient breathing spontaneously or being ventilated. Have a look at the breathing pattern. Does it look obstructed? Is there supracostal recession? Is the chest expanding symmetrically? Often the left side expands less due to left lower lobe atelectasis. Are there any scars or drains emanating from the chest? This patient has had a sternotomy. Usually that would indicate recent cardiac surgery given the inflammation around the wound. But occasionally the patient may have had a sternotomy for a retrosternal thyroidectomy. This patient has had a chest drain inserted, presumably due to trauma given the bruising on the right arm. Palpate and auscultate the chest. Does the patient have a parasternal heave or a thrusting apex? Find a stethoscope and listen. Now sometimes I will start by actually listening to the neck, to the carotids, to see if they have a carotid bruit. But then I will listen for heart sounds, and I'm particularly interested in systolic murmurs, looking for evidence of mitral regurgitation, usually from a dilated heart, aortic regurgitation, or a VSD. So the areas where you should be auscultating are in the lungs, are the apices, the bases, and for heart sounds. When you're listening to the lungs, you're looking for the presence of an inspiratory wheeze. This may be respiratory or cardiac. For breath sounds, are they bilateral? Can you hear anything in the bases? Is there evidence of bronchial breathing? Do you hear crackles? If you do, are they unilateral, bilateral? Are they in the bases, or in the apices, or throughout the lungs? Is there evidence of a pericardial friction rub, something that you will universally hear after cardiac surgery? Sometimes you hear it in uremia. Then, if you can, sit the patient forward and listen to the bases. If not, you can listen in the axillae, but that is not a comprehensive exam. Look for pressure sores at the back of the head when the patient is sitting forward, and look for sacral edema. Now let's review this tutorial. All critically ill patients require a full physical examination each day. It needs to be systematic from head to toe, front to back. Start with the head and work your way around the face via the eyes, nose, lips and mouth. And when I say mouth, I mean the inside, looking at the teeth, looking at the gums, looking at the tongue. Then move on to the chest and work your way from the middle to the sides. Inspect, palpate, percuss and auscultate. Next time I will discuss the examination of the arms and hands, the abdomen, the legs, the monitors, devices and drains. Join me then and I guarantee you'll learn something. That's the end of this first tutorial on physical examination of the ICU patient. If you're enjoying these tutorials, please subscribe on YouTube, give me some likes, leave me some comments, and if there's some topics you want me to cover in the future, please send me an email or contact me by whatever means to give me those suggestions. Next time, we'll move on to the lower half of the body. I'll see you then.